I'm Dr Rebecca Szabo. I'm an obstetrician and gynaecologist and medical educator at the Royal Women's Hospital here in Melbourne and also the University of Melbourne. And one of the things that I do is coordinate education and simulation, including the grand rounds at the Women's.
I'm Dr Kirsten Connan. I'm an obstetrician and gynaecologist in private practice in Hobart, having trained at the Royal Women's Hospital and held my first consultant post here. I'm also a medical educator. 3 years ago, I began the journey of doing a Masters in Clinical Teaching that involved looking at gender and leadership around Australia and New Zealand in the field of obstetrics and gynaecology. I'm also a board member for AGIS, the Australian Gynaecological Society, and I've got a strong interest in relationship to gender equity, both within the workplace but also in broader society.
Fantastic. Well, it was a very packed round. It was a very packed discussion, an hour and a half of incredibly intense points made, really.
Yes.
What were your takeaways for both? Whoever would like to go first.
Gosh, so much,
Yeah,
really.
yes. So I think on reflection, I really, the thing that I am most proud of and intrigued by is the collaborative nature of everybody working together, and that together we are genuinely stronger. One of the things that I have seen through non-traditional communities of practice, and I think really that's come about through my engagement with other people, primarily on social media and Twitter, has been that I have been able to meet some extraordinary people and have some really quite amazing conversations that otherwise would not be happening. And that's how I met Dara and Nila, and have had a whole series of conversations and been able to have those conversations opened up to me. So one of the intentions of today was to bring that conversation out of the echo chamber, and we heard the last question from the medical student of what do we do to bring it out of the echo chamber. Bring it potentially, Twitter is and social media is at risk of being an echo chamber because it's there for the people who are on it, but there are a whole lot of people, particularly possibly of the older generation, within the hospitals and within the healthcare workforce who were not engaged in that conversation. And so this was a way to bring it into real life. And I think we saw in person that the thirst for that is really there, and that it was really quite powerful to me to see that in real life, because I've been a part of it on a little screen on Twitter, and to see in real life, actually, this is a real thing, and if we continue this in real life, as anaesthetists, obstetrician gynecologists, surgeons, physicians, junior, senior doctors, those everybody that it impacts, that we can move the conversation forward.
Couldn't agree more. I think it's really interesting, isn't it, that this concept of working together, which is something that often I think is institutions and between craft groups and at different levels of our training, we do really poorly. And I think one of the great things about today was I'm hopeful that lots of people went away actually validating their concerns by hearing that actually for many people this is a genuine concern, but also by being empowered, knowing that there are lots of voices that are out there that are trying to also look for solutions. And I'm hoping that part of what some people have taken away is the opportunity to network in a really positive way, so create connections, as Beck was alluding to, whether it's through social media, whether it's meeting people in person, whether it's having representation from their hospital that they might have previously seen based on the innate hierarchy that exists in institutions. They might see now as actually an open door to be able to go and have a conversation and say, look, this is how I see things, what do you think, and what could we do together, irrespective of the level that they're in within their training, or irrespective of whether they're a doctor or a nurse or a midwife or
the woman in the cafeteria.
Correct. So trying to disrupt the hierarchy, trying to disrupt the belief that we should and do exist in silos, and it's time to break down those barriers and be in an open conversation so that we can all work together. Because actually what we all want at the end of the day is to see a transformational change in our culture, which is not just within medicine, not just within the Royal Women's Hospital, not just within O&G for Beck and I, but across the board universally. So, and to do that, we're all going to need to have a conversation to recognise where we've come from, to acknowledge where we are now, but also to be hopeful and be in a conversation together to move our culture culture forward.
Now, you talked about specific steps you could take, and you've done a great big study around the colleges.
Yep.
But you said there are very simple steps, and
Absolutely.
then, of course, there are more complex ones. Can you lay some of those out and just sort of give a pathway?
Yeah, absolutely. So I did my master's in 2017. I did it in a number of different components, but one of those most important was to survey all trainees and fellows through the ONG colleges in Australia and New Zealand. So just within my craft group, I think it's open for every craft group to probably do their own surveying and collect the data in that context. It had both quantitative components to it, where I could look at the statistics to see, well, actually, what is the gender representation within different leadership fields, such as heads of departments within hospitals, such as within university components, but also I asked broad questions around gender bias, desires for leadership, the role of gender quotas within institutions and also within the craft group more broadly, to find out what people wanted and what they saw as barriers. And actually, lots of that information was on the literature, but the data I got back just reinforced the literature. So before I talk about some of what those solutions are, I want to acknowledge that actually I think we already know the solutions. If you just ask the colleague next to you or the colleague next to that person, everyone already knows what they're likely to be. So really simple strategies, put in some great mentor programs, and the evidence behind mentoring certainly shows that that's often more effective if you have a mentor of the same gender. But that's not going to be the same strategy for everyone, but to formalise it within medical schools, within postgraduate colleges, within institutions. And I think that model of mentoring is a little bit different to what people originally thought it was historically, where you just be allocated a particular person and they were your person for life. Now what I think people are looking for is, I want a mentor who's going to help me with the issues around sexual harassment. I want a different mentor for someone who's going to help me in relationship to research. I need a different mentor for someone who's going to help me with career planning. I want a different mentor that I look to as an example of how do I find that balance for better in relationship to having a family or supporting my elderly parents or looking after my community. And so I think mentoring is one solution. Another solution is improving the flexibility that we have within colleges, within medical schools, within institutions in relationship to flexibility in the workplace and study. So being really intentional about part-time training, being really intentional about parental leave opportunities. That's another really big area as well. I think in terms of institutional strategies, a really simple one is to look at gender representation. So to either have quotas or targets, and there are pros and cons to both of those, but to recognise that often in high-level, top-level leadership positions, we lack gender representation in terms of diversity. And a really simple strategy is to put in a quota that says we recognise that actually there's value to have lots of different voices on the platform at top-level leadership. And I think that institutions all across Australia are increasingly having that conversation, and medicine is no different, and we need to have it.
Let's talk about that, because medicine is not only no different, but it's actually right up there in some of the poor offending, isn't it?
Absolutely.
And Simon Judkins was he's the president of the Australasian College for Emergency Medicine. He was here today. He's very committed to justice and equity, but he had to also admit that there's not a woman in the boardroom for that college. What do they do? Why don't they do it?
Yeah, it's a great question. So look, I can talk about the experience through my own craft group. Obstetrics and Gynecology has had a significant change in terms of gender representation. So over the last, well, now longer than 2 decades, we've gone from being a predominantly male represented majority to now being a female represented majority, both across the board within our specialist cohort and absolutely within our training cohort. So our statistics now in 2019 are that we have 83% of our trainees are females, and that's fabulous in relationship to their opportunities, but it's coming at the potential cost maybe of now having males who find that they're experiencing male gender bias, both to access the training program and potentially to be in the training program and to have the same opportunities. In terms of top-level leadership for RANZCOG, we've only had one female as a president since RANZCOG's inception, which I think is really disappointing. In terms of our board representation, we only have one female currently on our board of 8. This is a 3-year term that we've just started. We only had one female on our previous 2-year board term, and the board term before that was also just one female representative that was present. And I think that's really disappointing. So here we are as the craft group representing women's healthcare. We are now a predominantly female membered craft group, and yet we don't have great examples of female in leadership. There are plenty of fabulous females that I can look around in our specialty and see, but clearly there are barriers that either they perceive or that the institution imposes on them that are stopping them from having the equal opportunities of being able to be top-level leaders. And I certainly very strongly would recommend that RANZCOG, as with other colleges, think about the role of gender quotas, and rather than just waiting for the pipeline effect to unfold, which it will inevitably do in our unique craft group because we have so many females coming through, I think we need to stop, recognise where we've come from, acknowledge where we are now, and move really quickly before we continue to disengage our membership, especially the women within our membership who don't feel that there are pathways that acknowledge some of the challenges that are present for them in being able to access leadership, but also to re-envisage what leadership looks like and how you get there. So getting rid of those old traditional boys club models and now putting in new models and new visions for what a leader looks like.
Now, you presented those findings at the RANZCOG
yes.
scientific meeting last year, and I'm sure other people have heard them. Have they been rushing to your door to find ways to go ahead with that?
Yeah, look, I think it has been with mixed views that people have spoken to me since the ASM. The vast majority has been positive, and people who were delighted to have their voices heard and delighted to have someone who would platform their concerns. I want to acknowledge that RANZCOG then, in response to the ASM plenary session that I did, has now put together a gender equity working group, which I think is a fabulous step in the right direction in terms of our National Council, not our board but our National Council. We've certainly seen an increase in the number of female representatives. So our figure in the last council at a national level I think was 32%, and in this current council is 40%. So we're definitely seeing some slow changes, but that's still not happening at a top level, and that's what we see in medicine across the board. That membership of female representatives is increasing, that educational portfolios and mid-level leadership is now becoming increasingly diversified in relationship to gender, but there's still a huge barrier to top-level leadership, and without intentional strategies, we are just not going to see that shift in the next decade.
Beck, we're also seeing that in research. Can you talk to that?
I can speak a little bit to that. I think we're absolutely seeing the same thing in research and academic medicine. And the same is true in science and engineering and across the board in STEM. And I think realistically this is an issue for women in many, many industries, not just in science and medicine. I think in terms of what we know in research is that, again, women are involved in research and then getting to a particular point, and then to get them up from senior lecturer to associate professor and professor status, there are significant blocks, and there are lots of different reasons for that, which really mirror what we've been speaking about in terms of clinical medicine. And distinct lack of role models and mentorship. There are different programs that are being done to try and correct that, and I think the NH and MRC are going in the right direction, but as it stands, the number of grants that are awarded to women is still significantly lower, the number of publications, and all those things then impact ongoing promotion and ongoing ability to get those opportunities.
Just becomes a self-perpetuating cycle.
Yeah, absolutely.
Where one barrier then impacts on career progression, then that in turn limits another opportunity for career progression.
And I think, as Kirsten rightly pointed out, you need a complete disruption of the system, because the system has worked on one that is not flexible, and whereby, particularly in research, and I think a lot of work is needed to behind the scenes, or to get a research project up and running, or to get grants and publications, and a lot of that often happens out of hours or out of other times. And so if you have parenting responsibilities and other responsibilities that we know fall more to women, because I'm not for a second suggesting that men shouldn't do those things, but the traditional parenting model has allowed for men in leadership positions and in research and others to have somebody else at home to be able to do those things. And so if we're going to truly move forward, then we do need to look at the full system and have disruption. I know of a particular lab in the Parkville precinct where there is a male head of unit who has been incredibly inclusive to ensure that he has maintained female representation within the research group and provides flexible hours. And so that allows for, and this is both for women and men, but it allows for if there is a school drop-off or pick-up or other things, that therefore they're still engaged in the lab doing work but able to do those things as well. And I think this is much, whilst we're talking about gender equity and gender issues, the world looks entirely different than it did 50 years ago. So part of this is the modernisation of the workforce. I hate the term feminisation of the workforce. This is modernisation. The world has changed. We have ongoing demands on us for all genders, however you identify, which include that work is now almost 24/7 if you have emails on your phone and other things. And so people are bringing that home more as well. And I think realistically this discussion around gender and gender equity is something that is needed for women and men to ensure that we all have balance.
Absolutely.
You also said before that you hope it's the beginning of a broader conversation around equity, and that came up during the panel discussion from Sky talking about, and she did an interview with us before too, talking about the issues being from a rural and regional area, also lower socio-economic people. We know with Aboriginal and Torres Strait Islander people they face far greater barriers to being able to work at higher levels in health and medicine, etc.
Absolutely.
Where do we go with that conversation?
I think they're conversations we have to have, and I think that they're conversations we can have in a mature and considered way, and I think that's what we saw today. I think people are scared of having conversations that they think are controversial and are uncomfortable, partly because they don't have the answers, and partly because in the past I think in the past that there has been a risk of it being us and them, and people feeling either threatened or preached at. And I think Neela explained it really well during the round, that it is not a moral judgment. Like, we all have implicit bias, myself included, to different things. And so most of the time I would like to say that all of us, if there is a bias being placed, it's not because somebody is evil or bad, it's because they're not aware of it. And so part of having the discussion is us actually having some honest discussion about what's really happening so that we can move forward. And I think there's been a groundswell and a safe place to now have that conversation. Some of that is in response to what is happening in the rest of the world. And I think that's, again, what we've seen in terms of conversations in social media and media, is that women in medicine are looking at what has happened with women in Hollywood and Me Too movement and Time's Up, and in politics, and they're women as well. And they're like, well, hang on a second, what's happening in my neck of the woods? Let's have this conversation. And as we saw today, there are many, many men who also want to have that conversation, who are engaged on these issues, because there's clear recognition that this is better for everybody. And in healthcare, we are there to care for our patients and the community. And at the end of the day, addressing this, as well as diversity and inclusion overall, will make it better for everybody.
If there was a standout line for both of you from today that you would tweet, because you're both very active on Twitter, what would it be?
Well, I can tell you what I did, because most of the round, usually, yes, I am very active on Twitter. Hello, everybody. And usually I would be live tweeting, and I was transfixed by the round, and just really taking it in and listening and enjoying the conversation. So I tweeted very little during the round. For me, there were two standout things really. One was Professor Caroline Homer from the Burnett Institute asking about what leadership now looks like. And we've seen that in the past week with the New Zealand Prime Minister, with Jacinda Ardern. We've seen that leadership does not have to look abrupt and gruff and severe, and that women do lead differently. And that's a good thing, that we have diversity and various people at the table. And so that was a really standout thing for me. And again, an example of looking to other fields for examples of what that looks like. And because you cannot be what you cannot see.
Great. Was that and did you have a second one? Was that it?
I think the second one is what I mentioned before, which is the last question that was asked by the final year medical student, which it was, how do we move the conversation forward out of the echo chamber? And so the reason that stands out for me is because we had a wonderful conversation, but I hate talking without action. I would like for us to move this forward rather than just talking about it. And I think that that's the answer. How do we move it beyond the echo chamber, and what do we do next?
Fantastic, Beck. Thanks, Kirsten.
Well, I'm going to hold Beck's second point and make that my first point, because I couldn't agree more. I think one of the most important things that we should all be taking away is, where do we go next, actually? So having the conversation is great, and we need to acknowledge where we've come from and where we are now, but how do we actually empower ourselves and others with practical tools, but also the conversational skills to be able to continue to converse together, both in our workplaces, in our personal lives, but also as institutions and craft groups, to move the conversation forward, so we're actually transforming what that landscape looks like. And I don't have all the answers, but I'm really happy to have the conversation. I think lots of us are. From a practical point of view, I would certainly endorse what Beck's saying. I think we do effectively want to use this as a platform, as a call of arms to say, well, we've brought a number of craft groups to the platform today. What can we do now as craft groups collaboratively to use our individual knowledge, both as individuals and as craft groups, to work together? So I know certainly for the College of ONG, we've got a gender equity working group. I know that the College of Emergency Medicine has a inclusion and diversity group. I know that the College of Anaesthetists have a gender equity, I think, and they call it also a diversity group. And so there's just 3 out of a number of colleges already who think that this is a real issue and are looking to come together and provide solutions. So rather than working in our silos, this is a great opportunity for college presidents, or from a representative from each college, to come together at a national forum and say, where have we each come from? What are our lenses that we see in relationship to the problems? And actually, what are the solutions that our membership have put to us, and how can we use that information and all move forward so we can transform the whole landscape, not just for our craft group, not just for our individual institutions, but actually collectively across healthcare. I think that would be really outstanding as a outcome from today's hour and a half of being together. So that's my first one, which I loved from Beck. And my second one was the comment that Dara Cass made, and she had so many fabulous things.
Yeah, I was going to say, which one?
Yeah, that's right. It was outstanding having her there, and I think we were very privileged to have her presence. And I'm looking forward to watching what she tweets when she's at SMAC in Sydney next week as well, amongst lots of other rabid tweeters that we have that were there today as well. And she talked about a number of things, but the one thing that in particular resonated with me was the importance of separating out the conversation between well-being and gender equity. And I think that's a really important conversation. I also want to acknowledge that as an extension to that, I think it's really important to hold gender equity slightly separately from diversity, just in terms of the intersectionality of the conversation. That then means that we sometimes are distracted from that being not the only important conversation, but such a fundamental conversation because it affects everyone. Whereas some of the other conversations around issues like ethnicity and issues around ageism, they are absolutely invaluable conversations to have. I think gender equity is a great place to start. Not to neglect those, but to start because it's a conversation for everyone, whereas some of those other areas are a conversation that everyone should have, but not necessarily a conversation that everyone feels personally engaged in. And that's not to say they're not valuable, because I think they're absolutely valuable, but I think we should not be sidetracked by some of those broader issues and start with gender equity. And I want to go back to saying what Dara was saying before, in that I also think that we need to recognise that gender equity is different from wellbeing. It's a fundamental human right, and we should all be advocating for that for everyone in whatever industry we're in.
Thank you both very much.
Thank you.